Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a rare occurrence, breast lobular carcinoma presenting with endometrial bleeding. So this is a case of a 56-year-old female patient who presented with postmenopausal bleeding, and on examination was found to have a polyp. Whether this polyp was endometrial or cervical was not sure, so the patient underwent DNC. And as you can see here from the low power magnification, we have some atrophic glands that are entrapped within this sheet of infiltrating tumor cells. Now, on a slightly high power magnification, you can appreciate that these tumor cells are discohesive. Each tumor cell stands alone, have this plasmacytoid appearance in which there is eccentric nucleus and then abundant acidophilic cytoplasm, not much in the way of pleomorphism, and there was no evidence of brisk mitotic activity. Now, to zoom in further, you can definitely see here the appearance of the plasmacytoid-like cells where we have the eccentric nucleus, vesicular chromatin, fine, small nucleolus, and then we have the acidophilic cytoplasm to one side, and you can see some signet ring-like appearance. And even this cell, for example, shows a lumen and intracytoplasmic, intraluminal actually mucin deposition. And this appearance is quite unusual or foreign for primary cervical or endometrial tumors. It should always bring into the differential diagnosis metastatic carcinoma, most likely of breast and less likely of gastrointestinal, in particular gastric carcinoma. So along this line, I decided to start with doing some special stains, and as you can see, the tumor cells show this beautiful cytoplasmic positivity with PAS diastase. PAX8 was completely negative in the nuclei of the infiltrating tumor cells, whereas it showed some positivity in the entrapped normal glands as well as on the surface epithelium. In contrast, GATA3 showed this beautiful diffuse nuclear positivity in the tumor cells, whereas the entrapped atrophic endometrial glands were completely negative. Now, because of the discohesion of the tumor cells, the differential diagnosis that came into my mind was probably this is a breast carcinoma and more likely to be a lobular carcinoma. And this is ecadherin, where you can see the positive internal control with membranous staining of the entrapped endometrial gland versus the complete loss of staining in the background lobular carcinoma cells, further supporting the diagnosis. Now, ER showed diffuse strong nuclear positivity in the vast majority of tumor cell nuclei. The endometrial glands, the atrophic endometrial glands were at large negative, and the PR showed some positivity in contrast to the negative staining in the atrophic endometrial glands. Now, HER2 was quite unusual because focally it showed this membranous staining that was moderate to strong and was complete. So this I call this score 2+ equivocal, and we did FISH stain, and it came out as negative with no evidence of amplification. So the final diagnosis in this unusual but very interesting case is metastatic lobular carcinoma with the primary presentation as endometrial polyp. Now, remember that lobular carcinoma of the breast can have unusual presentations and can metastasize to unusual places, including the stomach, for example, as well as the endometrium or the fallopian tubes and the ovaries. Remember to keep an observant eye and an index of suspicion whenever the morphology does not really fit into a primary tumor, regardless of the site, being in this case the endometrial or the endocervical polyp. Now, further investigation in this patient actually confirmed the presence of right breast invasive lobular lobular carcinoma with bone metastasis in support of the final diagnosis in this case. I hope you find this tip useful in your daily practice. Thank you.